Hi, everyone, and thank you for joining us for our very last Fertility Q&A live of the year. Can't believe we're already at this point, but I really am excited. I'll be joined by Dr. Kenneth Gelman of IVFMD, and he's been helping us with these Q&As all along for the past few years, actually. He's full of information. He's been doing this a very long time, so I think you'll be able to glean a lot of information from that. And I also want to introduce myself if you guys haven't been on our lives before. My name is Farrar Duro. I'm a licensed acupuncture physician and reproductive acupuncturist. And I'm actually in Hialeah Gardens, but we work with patients all over pretty much, all over South Florida mostly. And we also work a lot with patients who are trying to conceive or are already pregnant, helping them have wonderful pregnancies, hopefully wonderfully boring and healthy pregnancies. And we also work a lot with their partners as well, so in many different ways. So we'll be waiting for Dr. Gelman to hop on. And while we're waiting, if you guys want to chime in with any questions, please feel free to ask. This is definitely where we would love to help you. And as we get into our final Q&A of the year, and we are going to be coming back next year with also about 2 Q&As a month. So that's going to be very exciting. We'll also be able to have consultations if you guys ever need any one-on-one help. We do encourage you to just give us a call, and we have free phone consultations too, just to kind of get more specific. We have someone's going through an egg retrieval next month. Yes, it actually, we do have a large number of patients that are going through IVF even at this point later, in the year. Let's see, Dr. Gelman is texting, but I'm not able to check my text messages since I'm on the live. But if he could pop in under, there he is, I see him now. Okay, cool. I'm gonna go ahead and invite him on. Let's see how I do. Oh, okay. Request to join. All right, so yeah, feel free to actually hop, there you go. Hop in and get your questions answered. Hi, Dr. Gelman, how are you?
How are you guys?
Awesome. This is it. This is our final Q&A of the year, so happy
Wow, it's
that
amazing,
you were able to squeeze it in.
Isn't that pretty amazing? Oh, it's already December. It's already the end of the year.
I know, this is crazy. Next year is going to be an even better year, and I hope everybody gets their goals met as far as their fertility treatment and everything in their lives, and I'm wishing everybody the best for that too. So that's what we're here for, and we're here to help. We have a lot of good questions that were pre-submitted, but we also encourage you guys to hit the little question mark at the very bottom, and that will actually allow us to show your question to everyone, and we'll be able to pop it up on the screen too. So or just type in the comments, like whatever you want to ask us. Pick our brains. We're here for you. So for those of you who do not know you, Dr. Gelman, would you introduce yourself? Sure, everybody.
Kenneth Gelman, again from Cooper City practice office, and one of several doctors now. They're adding more and more all the time. I think we have 12 or 13 now. So I'm there with Dr. Wood and Dr. Gerkowitz in Cooper City. And I'm very happy to be here every month that we do this. I think it's great. And we love to see all those people out there asking questions.
Yes. Yeah, definitely. And we kind of come away with more knowledge, because usually the question that you have, somebody else has it. So if you want
yeah, no question about it.
Usually that's someone else is going through that for sure. So we can jump on in if you like. Thank you for being flexible too, because usually we're here on Wednesday nights. Oh, thank you. Marianne, she said.
Yeah, I hope people adapted to change over to tonight, I guess.
I know.
We got the word out late.
It was holiday parties and everything going on this week, so I know it's
sure, I know. That's understandable.
But definitely we made it happen, so that's good.
No, that's great.
Very good.
I want to wish everybody out there a very happy and healthy New Year season and happy holidays, and just take a break.
Yeah. Yeah,
You
for
know,
sure.
so one of the things is very important is now's the time to kind of sit back and relax and just be with your family and enjoy the time, and
Hmm.
maybe go away, get some fresh air, go up north,
Yes.
if you have the chance.
Oh,
And just do nothing. Don't think about this problem at all if you're having it.
I've been dying to see some snow. I have a husky, and I keep seeing husky videos on Instagram where they're jumping in snow, and I'm like, I can't do that with my dog. He's not that, but one day I'm gonna take him in the snow. That's what I'm gonna
Yeah, one day. Yeah.
do. Awesome. So we have some questions. Actually, somebody I think just. Oh no, sorry. I thought that was a question there. Okay. We have some questions submitted earlier. There is a question about endometriosis. So we'll start off with that one if you want to take a look at it. And then we'll definitely get to some of the questions coming up in the chat as well. So, okay. So I'll read the question here that was, because there's a little bit of a part to it. It's someone who actually asked about, who has a history of endometriosis, and endometrioma is found during my egg retrieval cycle. Is it okay to proceed straight to FET from here? Or should I do something to treat the endo first, like Lupron or excision surgery? They had a hysteroscopy after their egg retrieval and then some small adhesions removed. I had one failed FET already and nervous about another. So what would you recommend in that situation?
Yeah, those are really good questions, actually. That's a tough case, because I don't think there's a right or a wrong answer here. But one thing about endometriomas and endometriosis, you just don't know how much it's going to affect that person's egg quality, because everybody's different. We have cases with, maybe minimal endometriosis, where egg quality really was affected. Other people with endometriomas and large endometriomas, we would figure everything would be problematic, and egg quality wasn't affected necessarily.
Mm-hmm.
So, in this particular case where they found it during the retrieval, so they didn't know about it before the retrieval, it sounds like.
Mm-hmm.
Or maybe they put a needle into something and thought it was a follicle and it was an endometrioma. I don't know,
Mm-hmm.
But, the thing is, what is the egg quality ultimately, and how do our embryos do? Because, very often endometriosis, if the egg quality is affected, the embryos may fertilize, or the eggs look dark and grainy.
Mm-hmm.
They fertilize, but they don't go past day 3, or they start to degenerate.
Mm-hmm.
And you don't get any blastocysts or anything to cryopreserve.
Okay.
And I just actually had a case like that she actually went through twice.
Mm-hmm.
And this patient had obvious endometriosis. She had surgery for it. I think she has an endometrioma, if I'm not mistaken. And I even treated her with Lupron depot before her second retrieval in an attempt, because her first cycle, the egg quality was poor. Same thing happened. So there's no guarantee that, even if you treat, that things are going to improve necessarily. There could be an underlying egg quality problem, period, having nothing to do with endometriosis.
I think she's
If
timing in
somebody's
about quality, though, that it was good.
okay,
6
so
out of 7.
if egg quality is good and she makes blastocysts, I think that's probably a good sign. I would not operate on the endometrioma. I would consider, Lupron depot now for 2 months with with progesterone add back to, keep her from getting hot flashes and losing bone. And maybe also make sure her, immune system, check cytokines. There is a test out there that I was just reading more about, that I've known about for a while, but, we've never really looked into. It's the BCL6 assay. It's not an ERA test. It's a biopsy, but it looks for a protein, which is some kind of protein that has to do with lymphoma cells or something. It's some kind of BCL6 protein that apparently is pretty elevated in situations where endometriosis is present and uncontrolled. And in
Mhm. Oh, I think I lost you, Dr. Gelman. I'm trying to get signal here. Are you able to hear us? Let's see if I move into this room. Oh, he came. Okay, well, Dr. Gelman, we lost him. So let's see if he can come back in, and trying to go into another room so we can get one more signal. But I think it was his signal, so bye. And so we'll try him again if he can just rejoin us. I don't think it's ours, so. Oh, well, bummer. Okay, let's see if he'll come back. Let me go to here. Okay. Okay, because everybody can give me like a thumbs up if they can hear me, hopefully. Oh, I see him texting, but I can't read it right now. Okay, it was, oh, thank you. Okay. All right. So maybe he'll get back, he can jump back in. Let's see if we can wait for him. But that was a really good question. And it was many parts to it. So I want to hear what he has to say. I think he did answer most of that question. So it was good to hear. Okay. I'm glad you guys can hear me. That's good. Thank you. All right. Let's see if we can get him back in. And then if not, we'll restart. But I went ahead and invited him back. It's easy. It happens, you know? And it was our last live of the year where it happened. Our last live of the year.
There we go. What happened to that?
We haven't had any glitches all year long. It was it.
Well, yeah. How crazy is that?
But it happened. All right. So
anyway, so I was talking about endometriosis, and you know, that patient said she has good egg quality apparently, and if she makes blastocysts, you know, and they're good quality blastocysts, then that's a good sign, I think.
Mm-hmm.
I would probably go on 2 months of Lupron depot with progesterone add back,
Mm-hmm.
and then make sure at the end of that I would check, you know, natural killer cell function, immune testing, cytokines, things like that to make sure everything was down, or consider one of those other tests like the BCL6 assay protein, which is a special assay you have to do, and your doctor has to know about it, and you have to order a special kit for that.
Mm-hmm.
That might be an intriguing thing to do in this case, so you know that there isn't, you know, endometriosis active at the time, but I would treat it ahead of time.
Mm-hmm.
And then go for your transfer, and then, you know, make sure you're getting enough progesterone. Now, you know, the ERA test is not getting great press lately. Yeah. So maybe your doctor will give you an empiric extra day of progesterone just to overcome any progesterone resistance there. So, you know, those are the things I would do.
Well, I think she is scheduled for a transfer next month. So definitely, if you have time, like, and it's frozen, you might as well. I mean, you know, it's good to have that conversation with your provider and see if.
Yeah, see if they're into stuff like that. You know, some doctors are going to be more proactive with that, I think. Others may not be. So, you know, decide, you know, what's good for you, I think. But, you know, talk to your doctor about it, because maybe they would consider, you know, going a little further here.
Okay, you're getting a little bit of response about that ERA comment you just made.
I am.
Yes, if it came back normal, are you saying that the ERA isn't that good? I mean, you still.
Well, there's some doctors, I like it. You know, some doctors don't. The issue, you know, is that there's been some studies showing no real benefit, particularly in good prognosis patients. who've had recurrent pregnancy failure, or even not, who haven't had it. The studies haven't proven that it's really an effective personal window tool, for some people. But, I think in certain cases it's definitely helped people. And, it probably is to a certain extent reassuring in certain people, especially if they've had several failures and they come back very pre-receptive. It's probably reassuring to know that we're going to use extra progesterone, or at least you have some objective data about it. There's some other ones out there too now, apparently, that are looking at, 50 and 70 or 100 proteins also that haven't been proven yet to be effective. But I think more of that kind of personal window detection, biopsy kind of thing is going to be coming down the pike.
Yeah. Okay. I mean, things do change and science changes.
Yeah.
Okay.
Yeah.
Yeah. It's very much an art form, all of this. So.
Yeah.
Yeah. And we have a question. I'm just backing up to our question that I saw earlier. Oops, let me see where it went here. About the benefits of adding HGH to an egg retrieval protocol. What would you say about that?
Well, it's controversial. I mean, nobody, again, has not proven that that's going to definitely benefit you. I mean, there are cases where I've used it in the past and it's not done anything to the egg quality or the egg number. In other cases, the patient's done very well, and whether it was the growth hormone or not, I don't know. For sure, a lot of us try to maybe add it empirically to certain cases where there's a lot of maybe diminished ovarian reserve, as well as maybe advanced age or egg quality, where we know we're trying to improve things, because the growth hormone seems to work, or supposed to work, synergistically with your FSH shots and things. So, I think if you can afford it, because a lot of times obviously it's not going to be covered, insurances, you got to be careful also with the insurances on that. If you have any type of insurance coverage for IVF, if they see something like growth hormone in your protocol, they may kick out the whole cycle, or not pay for certain things, or not pay for your meds or whatever. That's happened a few times. So you got to make sure before you get a prescription for it, and before it's written in the chart as part of your protocol, that the insurance will either accept it as part of your protocol, or if it's cash, it has nothing to do with insurance. That's different. And then, you also have to be aware that it's not FDA approved for the use we're using it for. Of course, there are many medicines we're using in this field that are not FDA approved for the use that we're using it. For example, Lupron.
Femara too.
Femara, yeah. But it's accepted in the medical community, because doctors can prescribe drugs for anything, but it's not FDA approved. And and Femara and Lupron, those drugs are state of the art. Doctors all over the world are using them, so it's nothing unique. But growth hormone, not the FDA, the feds are looking at that, because they approved it for growth hormone deficiency for people, for example, obviously kids, but also adults who have growth hormone deficiency, where it's documented by, like pituitary disease, where they've had, pituitary resection, and they have growth hormone. Most of them have growth hormone deficiency after something like that. So they would be candidates, and insurances would cover it. That's really the only documented use, and then obviously people are using it off-label for bodybuilding and anti-aging and stuff. But you got to be a little careful with growth hormone, because it could make things grow that aren't supposed to.
Yeah.
So if you do get growth hormone, I would advise you to get a mammogram before your IVF, even if you're young. Just make sure nothing's going on there.
Is there a marker like is it IGF-1 or one of them that actually
IGF-1? Yeah, I've measured that. And, I don't know how useful that is just as a baseline measurement
Mhm.
because, you really should, to really determine growth hormone deficiency, women who are going through infertility aren't likely to be growth hormone deficient, but, there are provocative tests that you have to do. I think you have to do either an insulin tolerance test where you have to make somebody's blood sugar go down and measure growth hormone and then L-DOPA, you got to give them L-DOPA to stimulate its release so you can actually see at various intervals whether growth hormone levels go up.
Mhm.
Nobody's going to do that.
Yeah.
And women, who are going through infertility who are healthy, who just aren't getting pregnant because of, endometriosis aren't likely to have growth hormone deficiency. So,
Mhm.
nobody's going to do that test. And so I don't think they'll accept a low IGF-1 level. Maybe. I don't know. I've never tried that.
Mhm.
But, that I don't think that's going to be a criteria. If the insurance is smart enough, they're going to turn it down if it goes to insurance at all.
So have you seen good results though? Like more good results than bad, or like is it kind
Well, I've seen some patients do well with it, but you never know for sure whether they just did well because it's their second IVF cycle and we maybe tweaked their protocol a little bit, or they just happen to do better because statistically sometimes patients do better in their second cycle.
Yeah.
And it really wasn't the growth hormone. And you're going to say, oh my God, the growth hormone made a huge difference.
Yeah.
Well, maybe it did,
Yeah.
but there's no objective way of telling that.
That's okay. Every cycle's unique too. Everybody.
Yeah. Yeah.
And there's a
And it's
question.
expensive.
Yeah. There's a question. What is the most important thing to look for in an IVF lab/embryologist?
Competency, and obviously they have to be dedicated, extremely dedicated. And experience. Experience really matters. And that comes with time, obviously. But I think dedication, the ones we work with here, extremely hardworking, dedicated people. They got long hours. They're working in the dark for long hours. They're doing these, ICSIs and biopsies and egg freezings and, all kinds of very complicated things.
Yeah.
It's a pretty impressive field, let me tell you.
It's really interesting.
It really is. I mean, but it's a tough field. It's a very tough field. They're under the gun, to obviously produce and, not to make any mistakes. It's very, very, very difficult. It's not easy. So dedication and,
Are
be
the
ready to work very hard.
I
Yeah.
guess mediums they use more or less the same from lab to lab, or do they have like different mediums you think for different labs that they prefer, or like are they pretty much?
Well, they'll use media, in all our offices, they'll be standard,
Yeah.
They won't be changing from lab to lab. I mean, the embryologists will be rotating, but the lab standards will be the same.
Mm-hmm. Yeah. I mean, I read sometimes about certain mediums that actually help the embryos grow better and do all these different things, but I don't know much about that field, so it'd be we had an embryo. We had your chief embryo.
Yeah, we should you should plan on that next year for sure, having Inya back or one of the embryologists to talk about what they do.
Yeah.
I think that'd be great because that'll be a very well attended meeting. When they come on, everybody listens.
Yeah. Yeah. A day in the life of an embryologist. That'd be awesome.
Yeah, no, it's very, very, very tough. It's very impressive what they do.
Yeah.
And a lot of times, honestly, the patients come back and they send the doctor nice notes and gifts and thumbs, and but we're really part of the team. We're not really, the whole team. Maybe we're deciding on their game plan and we're like the captains maybe and guiding them through, but there's a whole team. Including nursing, including acupuncture, including embryology. I mean, these are the people that really deserve a lot of credit for success.
Yeah, you've got really an awesome team there, and nurses and everybody.
Yeah, these people, they're very experienced and they know what they're doing, and people can trust in knowing that. That's a very important thing when you come to a practice like this. That the experience is there.
Yeah, I think right when the pandemic, I guess at the end of 2020, we did actually, I think it might be on our YouTube channel, a whole, it was almost like it was a webinar actually on like what to look for in your team and who to, bring into your team when you're trying to go through infertility treatment, because it's like you're really trying to pick your players, like who am I going to have your if there is a therapist, also that's important. Like
Oh
my
yeah,
health is very
everybody, the mind, the body,
important.
very, very important.
Yeah.
That's why they need you. You got to keep yourself well
Yeah.
because you're their mind body person a lot of times.
The self-care is crucial, and
Crucial,
yeah.
crucial.
And sometimes it's the first time that someone's actually gone deep into the self-care when they're about to do this. It's the
No,
preconception.
absolutely. I mean, and it's great. It's absolutely great. You know what you guys do.
Thank you. All right. And same goes for you guys. You need to take care of yourself as
Yeah,
well.
no, we try. We try. You're right.
Like, you're gonna take a good vacation after this. It would be good.
Well, I take a little time off. Obviously, yeah, but I'm good. I'm good.
Yeah.
I try to, eat well and do what I tell other people to a
And
certain extent.
you're good. You practice yoga, right? So yeah.
Yeah, I do. I do. So that helps me, and I play the drums, so
No,
I like that. So I do that a lot. So
I
I'm
think that's
happy.
what to do next year on the live. You should play the drums as an
Oh
intro.
yeah, I'll do a concert for you to.
Do an intro like with the drums.
No, well, something. If actually, I'm building a recording studio,
Ah,
and I work with some pretty professional musicians, and if we're gonna put together some videos,
yay. That'll be awesome.
so we'll put them on Instagram when we get them done.
Yeah. Oh, that'd be awesome. Yeah. I think we need
Yeah,
a drum roll like as our intro next time.
yeah. Bum-ba-da-da-dum.
Yeah. Awesome. Okay. And a very good question. We're gonna like hit the symbol. That's awesome. All right. And as far as the questions go, we do have a few that were submitted earlier, so let's get to those first. Just I think two or three, and then we'll get back into our chat because we still have some time. There is a question about medicated. Okay, are medicated FECs more likely to have C-section births than natural or modified FET?
Yeah, that's a good question too. That's a real good one. There's some data, it's been out there a while that it's been known that, FETs are programmed cycles,
Mm-hmm.
which means cycles that we run ourselves. We put people on medications and shut off their periods, and we program their endometriums with hormones. It's been known that there's a higher incidence, not everybody, but a higher incidence of larger gestational size, or for the baby. That could possibly be one risk. And the other thing that is more seems to be a little more common, not again in everybody, is hypertensive disorders in the patient. So it's theorized that because the patients who have programmed cycles like this don't have a corpus luteum present, which is where they normally would ovulate. They have a corpus luteum, assisting the reproductive process, assisting implantation. Corpus luteum has a function even after implantation, progesterone production, but also some other hormones. I think there's one called relaxin or something like that may be produced that helps actually not control blood vessel development and things like that, and blood vessel diameter, in the developing placenta and stuff. So it helps decrease the resistance in the vessels. So in the absence of relaxin, when there's no corpus luteum, there may not be that effect. So there may be a higher incidence of, hypertensive disorders.
I didn't know that.
Hypertension, huh?
I didn't know. I didn't know. I really didn't think about not having the corpus luteum, how that would affect.
Yeah, well, that's the theories now. So but the situation as far as pregnancy is concerned, even getting pregnant, the natural cycles as well as the program cycles really pretty equivalent in terms of the pregnancy rates. It's just that the natural cycles are difficult to manage because, like certainly in our practice, it's difficult because that would basically guarantee they'd be going to Miami for a transfer because, as of now, our practice in Cooper isn't 24/7 yet. And, so the transfer would be at, odd times, whereas we can program everything to have a transfer on a certain day with a certain doctor. It's obviously a lot easier. And the majority of patients do pretty well with it. They do well in terms of the preps. Occasionally somebody does not do well with the prep, and maybe those patients get a natural cycle transfer, or if they actually request it, we'll do it. But there may be some complications with medicated cycles, and that's probably what this patient's asking. So there may be a higher risk of a C-section, especially if there's hypertension involved or any preeclampsia. It's not so much preeclampsia, it's hypertensive disorders, of which preeclampsia is one of them.
Yeah.
So there may be a slightly higher risk of that. I don't know the exact data on that, whether that's the case or not for sure. But, good things OBGYNs are on top of that stuff.
Yeah, and if you've had any surgeries for fibroids, things like that's going to put you more at risk for C-section, obviously. And
oh yeah, no question. But just the one thing is that we don't really think about it as much.
No.
But we should really tell patients about that possibility.
No. And I was reading something that came out about double embryo transfer not being great either. That there are some adverse effects. Interesting, but I guess from Sweden they were studying this, which you guys don't really do a whole lot of those anyway.
No.
But
we don't.
A good thing.
Huh?
Oh yeah.
Occasionally, we still do one or two of those, but on occasional case by case basis where we're always a little leery of those now. Getting a little gun shy with them because of the complications we've seen over the years with those.
Yeah, it was something about the health of the babies for a little bit, like
it's just weird because you look at pictures. I mean, I still get some Christmas cards from people from many years ago where we were putting a lot more embryos in. We weren't thinking too much about that.
Yeah.
And I'm getting cards from the triplets, and all that. We don't see those anymore.
Yeah, that's true. Yeah, we did have the twins before, but I mean, and thank goodness there's definitely risk of prematurity and
oh, for sure. Yeah. That's like a given almost.
There is a question about acupuncture, and is it helpful and can it increase your AMH? And I don't know if you have any answers as far as AMH goes, because we don't look at, as acupuncturists, I mean, I don't look at the AMH as crucially as an IVF doctor, I guess, would, because I believe that's more geared towards IVF in a way of like the dosages, the things you guys need to do and all that. I just find that if someone's coming in who's just trying to do like preconception treatment and that sort of thing, it's helpful to know if they haven't, but it can fluctuate too. So vitamin D can actually increase it, and then it can go back down in certain things. So I don't know if there's been any studies about acupuncture and the AMH per se. There's definitely a lot more studies on blood flow, on the response, on the success rates, but I don't know anything about AMH. So I don't know if you've seen any.
Not specifically, but I've seen studies on uterine artery resistance indexes and things like that, how that decreases with acupuncture. So blood flow to the ovary and endometrium obviously are improved. So you would think that more blood flow there would help things. But I think it's an overall pattern that the patient has to follow, not just necessarily one thing. So, because they're going through acupuncture, I would hope that they're on a, Mediterranean diet and, stress reduction pathway and, maybe some DOR supplements, things like that, maybe will not necessarily improve the number that much, but maybe the antral follicle count will look a little bit better, So, and again, not everybody with a low AMH has a death sentence either.
Right. Yeah. No, I mean, that's we've seen.
I just had a case today. Very low AMH. Well, she's had a history of this. Very low. She's 32, and she had 2 cycles in New York, and very low, zero point 0.6, zero point 0.5 AMH. She was probably 28 then. But they pushed on her, and they got eggs. They got, same thing here. I started a stimulator, and she was going nowhere, and I said, "Oh my God, we're not going to get anything." But I decided just to push, and she ended up with cryopreserving 3 embryos.
Oh, nice. That's awesome.
So you never know.
Yeah.
Age is a big factor here.
Mm-hmm. Younger,
Huh?
definitely are seeing younger. I don't know, when I see the blood work, it's like, wow, you're 32, you're 30, and you have an AMH that's half of what it would normally be. Yeah. That's a sign, like, okay, probably not wait. You need to definitely talk to a team, get someone together to actually start things in order. But it can go up and down. It can fluctuate. I don't really think that that's going to be the determining factor as far as egg quality and things like that.
No, it's not. It's not. It is not. And a low AMH doesn't. If the age and the prognosis, the age is in your favor, it doesn't necessarily mean you're not getting pregnant. Maybe you'll have low numbers, but you may have very good egg quality, so that maybe embryo banking or something might be a reasonably good thing to do for you.
Yeah, for sure, definitely. Oh, we have a little question here. Let's see. I think, let me pop it up. Okay, here we go. It's a glutathione question. Does low glutathione affect retrieval results?
Well, it could. I mean, it's an antioxidant, things like that. So theoretically, we'd like to maximize that beforehand. In terms of what your egg quality might be. Is it going to affect it? It possibly could, but there's so many other things that could affect it. How do we know it's glutathione alone? That's a very hard question to answer, but I would think we would try to maximize that ahead of time. Or if you had poor egg quality and you ended up getting an inflammation panel, that usually is part of it. Or if you work with Marta in our practice, she'll definitely check that.
Yeah.
And all those things will be maximized to the extent that we can maximize them. And then, hopefully that helps. But there's so many other things that could be factors here, not just glutathione.
An interesting study I read about NAD actually helping with egg quality.
Yes. Yeah, there's been some stuff about that too. And that stuff, I think, is that there's some stuff also with rhodiola. Mm-hmm. Rhodiola combined with NAD.
Yeah.
Interesting.
And orally, you can take it up to let's say 2 months prior to starting stimulation, if that's something that that is a concern, and it is for a lot of people the main concern, egg quality, right, when they're going through this. So as long as you have enough for it to work, but like anything, you need time. You wouldn't want to just start it right, like for stimulation.
It gives you good energy too.
It's great. I mean, it's a kind of it affects cellular aging. So if anything that
well, listen, it keeps you younger. Keeps us nice and handsome and pretty. What the heck, right? We'll be doing this till in our 80s.
Yeah, right. Yeah. Well, I mean, definitely.
All because of rhodiola.
Yeah. They have, infusions of it, but that can take hours. So I think that just
oh, really?
Yeah, and any infusion can take three hours sometimes. But it's very big in anti-aging kind of community there, and also reducing oxidative stress. Like, I think when we read studies about oxidative stress, something slowing it down, that's a clue to me. Like, okay, that could be affecting egg quality too, like in a good way. It's anything we can do to help slow it. It's a fact of life that we're going to go through oxidative stress, but the thing we can do to slow that down would be helpful for sperm quality too, I would think. So
yeah. I think anything that you do that obviously helps your heart helps your eggs.
Yeah, and I mean, this study was actually done in 2020, which was interesting on mice, but I don't think they've replicated in humans. Yeah, but the CoQ10 study was also done in mice, and that was also
that was Japan.
Mm-hmm. So so there's stuff out there. I think that we can look, and we have a lot of stress in the environment, and also foods we're eating, all kinds of things that definitely
could have an impact. But the glutathione question, it's good to see what that is, and then you can have things like NAC and things like that to actually raise that glutathione level too.
Yeah, no, there are supplements that'll help it.
Mm-hmm.
Yeah.
And there was another part to the question here about the low IGF-1 affecting egg quality. Like, how would that affect egg quality? If you have,
It's a good question. I mean, again, depending on the age of the patient, how accurate is that assay? Do you really have, a low IGF? How old are you? I mean, you're 32 and you have a low IGF. From what? Is that an accurate assay? Do you have growth hormone deficiency? Do you need to look at that? I mean, growth hormone deficiency might affect egg quality. So I have a patient now with a pituitary problem, like I was saying before, who had a resection, macroadenoma. And I proved already she's got deficient or secondary hypogonadism because we couldn't stimulate her gonadotropins increase.
Mm-hmm.
So I measured her IGF. Her IGF seemed to be normal, but I suspected that she's got low IGF-1, IGF and growth hormone dynamics. So I sent her to a general endocrinologist. I'm waiting for the result of their provocative testing for that reason. But this patient will do better with growth hormone before I even, freeze her eggs or do anything like that, because growth hormone may be synergistic to that whole FSH, LH system in stimulating eggs. It's permissive, So if this person really has low IGF, I would look into it. It might affect their egg quality.
Mm-hmm.
But I would question why she would have low IGF if she really does.
I think
that may not be an accurate assay.
Right. I mean, I think actually we do know this case, and she has had a history of not responding well to stimulation. So she never, it's been hard for her to respond. So it could be playing a part in it, perhaps, or not.
Well, I guess, if you didn't want to do all the testing and all that to find out if it's real, try her on growth hormone and the stimulation, see what happens, or start it a month or two before.
Yeah.
But you're doing it off label, unless you can document somehow that she's got growth hormone deficiency. I would try to document it. Mm-hmm. And get it approved, because, if she's going to go on growth hormone, it's going to be very expensive. And then, you're using it in a non-FDA use there, mm-hmm. which, I don't think is great. But, I would probably send her to a general endocrinologist to find out, does this patient have growth hormone deficiency or not?
Okay. That's good to know. Yes. Awesome. Oh, you do have a few more questions that we need to get to before we get back in the chat here. What is a good fetal heartbeat at 6 weeks, 5 days?
Well, between 100 and, it's usually around 100, 120. I mean, it's going to go up, it goes up between 100 and 200 by, 8 weeks, 9 weeks, 10 weeks, it's starting to slow down already, 10 weeks or so. So, but yeah, it's usually up there. Sometimes it's 130, 140, depends, but anything over 100, usually.
Yeah, and how do I know if inflammation from endometriosis needs to be treated? Can a hysteroscopy see that?
Well, a hysteroscopy is not going to necessarily see that. A laparoscopy may, but, we don't do a lot of laparoscopy so much anymore, mm-hmm. Unless there's a specific reason maybe. But, there are tests for inflammation, I mean, maybe your CA-125 is elevated. That might be one test, natural killer cells, cytokine assays, or if they get a BCL6 assay, that might show elevations. Mm-hmm. Do you have pelvic pain? Are you uncomfortable, getting mid-cycle cramping or intercourse painful, et cetera, et cetera? Are there objective signs of inflammation?
Yeah. And the protocol for FET of positive ANA.
Well, what does that mean? A positive ANA, and there's really positive ANAs of, really elevated values, and somebody's got lupus.
Oh, there's actually a second part to that. Tested positive ANA/normal natural killer cells, blood clotting, blood test normal range. What to do next?
And the ANA, how positive was the ANA? I think it was just like 1 to 40. I wouldn't do anything about it. But if it's, significantly elevated, 1 to 360 maybe, you may want to get, a rheumatologic workup just to see. Probably also this could be, I'm not saying it is, with normal natural killers and all your other things, maybe it's a false positive.
Mm-hmm.
There are false positive ANAs out there a lot. We see them a lot. People have gotten antibiotics and they develop a false positive ANA. We get people with false positive hepatitis C all the time that they have hepatitis C.
Mm-hmm.
They freak out. Or an HIV test.
Oh, okay.
False positive. So that might be, false positive.
Mm-hmm.
But I'd repeat it, and see what the titer is, and if necessary, have a rheumatologist go over you and make sure nothing is active
Mm-hmm.
before you get a transfer. So, if there's anything there that maybe they want to treat, maybe a little low dose prednisone.
Okay. Yeah.
Or Plaquenil sometimes is used too.
How long should you wait to repeat the ANA that you usually recommend? Like, just to make sure.
Well, I would probably repeat it, in a week or two and just see if it's real or not.
Mm-hmm.
Just to know. I mean, if it's significant, if it's like 1 to 640, something like that, that might be a significant elevation. I'd probably get her checked out and see if there's anything like subclinical lupus going on.
Yes, and I'm kind of jumping around, but I'm like, I want to get everybody's questions in, the final questions of the year here. At what point during FET do you recommend acupuncture? And we do actually treatments way before the transfer, hopefully. And some patients maybe are only able to get acupuncture the day of the transfer, but we try to do, with our patients, we try to see at least hopefully 2 months prior to that time. 2 or 3 months would be optimal, and just work a little bit on optimizing everything we can, stress level, blood flow, nutritional recommendations, and kind of get our everything in order. And hopefully by the time you get to the transfer, you're very, much more relaxed and ready to go forward. But usually we try to do our treatment anyway. It might be different for everybody, but our treatment's usually once a week during that time, and then twice a week about a month prior to the FET. And then we do also treat after the transfer as well, and then on the day of transfer too, if that's something that the clinic that the person goes to offers. So we try to be there within reason if we're in this area. If obviously the transfer's in Pennsylvania or somewhere and we can't be there, but if it's in Miami or Broward, we usually try to be there. And then afterwards, I usually see patients twice a week till the ultrasound shows a heartbeat. We're hoping to kind of get to that point where the waiting period is just a lot of anxiety, a lot of stress sometimes about the numbers and if everything's doubling, and getting to that point. And hopefully, after that, most patients are feeling a little better. We are starting to work on the nausea, vomiting, preventative points, things like that. And week 12, 11, 12, actually we have, I think, about 6 pregnant women right now that nobody has any nausea. They keep saying, like, are you fine? Are you good? Like, yeah, I'm good. Like, nothing. There's any pain? No, nothing. That's exactly what we want, So we try to work on enjoyment of the pregnancy because you earned it.
Oh, wow. Wow,
So,
that's good. Huh?
yeah, and that's it. And it's kind of like you guys, when you graduate your patients there, it's like bittersweet. You're like, oh, but we've been together so many months now, and then we see patients back at the end. But a lot of times we have a great massage therapist too who does prenatal massage. So we see patients during the pregnancy that just come in for, stress relief or back pain, things like that too, just to help, but and we've been, doing this for a long time. So some of our patients are now approaching menopause that have teenagers from IVF transfers that we went to like 15 years ago. Well, So, working in that stage of their lives, many, many different ways. But it's just, whatever you can get in as far as acupuncture, it's a good idea. And some people will need a little bit more than others. But I think that, at least starting the process, beforehand. And if it's like the transfers tomorrow and you want to get acupuncture, hopefully, that's also a possibility. You can do that. But it's just definitely, I think something to think about implementing probably when you start making your appointments and things like that for getting into the IVF center and all of that. So,
Right. Yeah,
uh,
I agree with that.
there was a rhodiola question here about, is it in pill form and IVs? Could you tell us about the dose? That's in rhodiola. It's definitely in a lot of supplements. That's for sure. I'm not sure if they've combined it with the NAD yet. I did find one that actually does have a certain amount of things like resveratrol for egg quality and NAD, but I'm not sure about that one. So I have to double check on that. But I'm sure you can get it separately, right? Do you know of any
Rhodiola?
that you're
You
just
can buy it separately.
separately? Yeah.
Yeah, Whole Foods, I think, has it.
Yeah. Very good. Oh, okay. And we have a question of, oh, sorry, there's some little question box here. We have a question that, I guess to clarify, you said that having pain during your ovulation means that there is inflammation. I just started to feel this pain during, during ovulation the last 2 months. I had low-level endometriosis found through laparoscopy in 2017. Pain during ovulation. I mean, you could have a little pain. Metal smirts is like normal.
Yeah, no, that's normal. Yeah.
Um,
So I'm not sure what she's referring to.
maybe,
She probably has mild endometriosis, but the
yeah.
pain you're having really doesn't reflect it.
And then this is a question back to the HGH. Like, how many units do you recommend for priming, and how long before starting stimulation?
Well, they have specific protocols that they use.
Mm-hmm.
I've seen some practices use it for 3 months before they actually start. Some people start it, maybe a month or two, but most, our practice, we usually start it with a stimulation. And I think it's 50 units, 50. I can't remember the exact dose that we were using,
Mm-hmm.
but it's a moderate dose, and some people do get side effects from it. They get swelling of their joints. It retains fluid.
Okay.
One of the side effects. So, you got to be a little careful with it.
Okay.
So if you have a tendency towards hypertension, it could cause hypertension.
But can you do more leg presses when you're using it?
What's that?
Can you help
Yeah.
for leg presses?
More leg presses? What'd you say?
To help with the muscles. Yeah. I do know it uses a lot in bodybuilding, and that's the thing. So I'm sure different dosages and different.
Yeah. Oh, yeah. They use pharmacologic doses.
I had a frozen embryo transfer. My beta is tomorrow. How many HCG? What are you looking at? Would you expect to be normal more than 5? What do you like to see in the HCG? I think that was the question when you have a pregnancy test that you're looking at.
In a beta?
Mm-hmm.
Well, frozens usually they're over 100. I mean, 250 usually on occasion. Sometimes we see them lower, and they do go to term, some of them. But usually they're pretty good. 250, 350.
Triple digits is reassuring, I guess.
Yeah, it usually is. Yeah.
Very good. Well, good luck tomorrow. Crossing fingers.
Yeah.
Awesome. And let's see. I think we got to most of our questions here. Let's see. They were winding down the last few minutes here. I think. Let me see here. Oh, we have a few more over on this side. What's the thinnest lining you'd recommend proceeding with for FET?
Well, it should be under. I'd say under 7 is probably not great.
Mm-hmm.
So 7 would be the lowest we would try to do it with. Although there's been pregnancies with linings thinner than 7. There are receptive linings, and that's where I found or thought that the ERA test was useful. This was a number of years ago, where I could not thicken somebody's endometrial lining. And I think we're doing program cycles. Maybe we tried a natural cycle. I can't remember now. But this was a number of years ago, and it wouldn't get over 6. And she ended up having an ERA test, which showed she was pre-receptive, despite having an endometrial lining of 6. She was pre-receptive by, I think, 24 hours. So we decided to give her the extra 24 hours of progesterone and transfer her, pregnant.
Oh, gosh.
So at that point, I was kind of buying into the ERA test, because we threw our hands up at that point after trying all the different various ways to thicken the lining. And, that test, I think, helped me in that patient.
Okay. So it's good for some certain situations.
Yes.
I think someone asked about mock transfers. Do you still do those, or do you recommend?
Well, we do them. Sometimes we'll do them way ahead of time, but normally we'll do them right before the actual frozen, because the way we do our transfers, we put a mock catheter in there first and kind of feel our way in there, and then take out the inner catheter, and then the embryologist will feed the embryo catheter with the embryo in it actually right into where the outer catheter has been placed already. So a mock trial has been done. And don't forget, some of the other testing you've been doing, you probably have done, or SIS or an endometrial biopsy. All those kinds of things are where we have to get into your lining. So we already know we have most likely no problem getting in there. And in certain cases where maybe somebody's had problems beforehand, where we know they have a history of that, we'll do a trial transfer, in the month or so before they get transferred.
Okay, very good. And that's good to know too. If there's maybe something going on with the cervix, or it's harder to get,
Yeah, well, we're not expecting that, because theoretically, all that stuff's should have been looked at ahead of time, most of the time, not all the time, but most of the time. And again, the trial will at the very least, you'll get a trial the day of your actual transfer.
Okay, so that's pretty much done in every patient, is what you're saying.
Pretty much, yeah.
There's a question about can you do mock transfer day or baseline ultrasound? Do mock transfer day.
What was that?
Can you do a mock the day of transfer or baseline ultrasound? I guess it's either or do you both? You do an ultrasound during the transfer.
Yeah, we do. We do.
So you said it could be done like on the day of the transfer as well, the mock
transfer. Yeah, that's exactly what we do.
Okay, can removing adhesions during hysteroscopy help lengthen lining during the next transfer?
Yes. That's why hysteroscopy is done.
Thicken lining.
Huh?
Thicken the lining, yes. Yeah, it could be. Removing the adhesions, yeah.
Absolutely, yeah.
Very good. And then I think we got everything, guys. We did it.
We did everything?
Ending down yes. We only had like one other question left about switching doctors in the same practice. Can you switch doctors in the same practice? Is that something?
Yeah, people do it all the time. They, there's nothing, it's nothing personal. It's just you want another opinion, or you just want, a male or a female doctor, So it's done all the time. It's nothing, you can absolutely do it.
Very good. Yeah, and everyone is amazing there. So with you guys anyway, I know that. So I haven't met the new doctor yet, and I'm sure that they're pretty awesome too.
Yeah, I think there's another one that they're interviewing too. So I think you're like 2 or 3 behind. Actually, there's another one in Orlando, I think, that I have never met. There's a few of them actually I have not met.
Yeah.
There's one in Boca that goes to Boca and to Jupiter. I don't really know her very well. And so
Yeah, and that you have a good choice of like location too, or if you need to go.
Yeah, the locations are very good. So, you know, Boca obviously is a popular location for us, and
Hmm.
Jupiter,
Yeah,
Naples.
very good. And
Yeah.
yeah, so where you have to go where you're comfortable. I think that's what's very important
Yeah.
with any
Yeah.
kind
Or, you know, if you want to see, like, for example, if you live in Miami or if you live in Palm Beach and you decide you want to see me, for example, that's no problem because we could do our visits virtually a lot of times. You know, now with technology the way it is, it's great because you can see patients wherever,
of. Yeah,
you know.
definitely. Yeah.
And I had a patient from Norway.
Oh, cool. Very neat.
So you know, I mean, we're getting patients from other countries.
Hmm.
So, you know, it's not a problem anymore. It
Yeah.
really isn't.
Yeah, that's the only good thing that came out of COVID was it speeded
No, it's,
knowledge.
and this,
Hmm.
what we're doing now, that really came out of COVID, right?
Yes, it did come out of COVID. I remember that.
It did because, and then now, you know, it's so great for people. You just stay home, you listen to a good lecture or, you know, whatever,
Hmm.
or you talk to your doctor on online. It's great.
Yes, everyone follow Dr. Gelman. Broward Fertility.
Yes. Yeah. Well, you look for my drumming videos.
Yes.
Yeah. Yeah.
You're going to create a reel. I'm going to see you create your first reel.
Yeah. That
Okay.
should be fun. Well,
Awesome.
look for those next year, hopefully. Yeah.
Oh, okay. Being soon released. That's awesome.
Yeah.
And if you guys want to follow us, we're at FL Complete Wellness. I appreciate it. And we'll,
Yes, go see her, everybody. Go see her. She is the best.
oh,
People love her.
I'm like very, very honored.
The
And
most dedicated.
thank you. Hey, I'm
It
still
means a lot.
outing.
It means an awful lot.
No, thank you. I really I love what we do. This is amazing. It's amazing work,
Yeah.
super rewarding. So
Helping people is great.
it's awesome. And so if anyone has any questions, feel free to also ask us on our next live. We'll have more coming in January.
Absolutely. Yeah, I'll be back in February. I think January is booked with somebody else. But I'll be back in February and then I think every month.
Yeah. Yeah. Awesome. Yay. Well, I love doing these, and you guys are the best as well. Thank you so much for everything this whole year. Those of you who've been joining us, and if you want to share this with a friend who's struggling, that would probably be very appreciated. I'm sure.
Yes, we do.
Yeah.
We'd love to see you. We'd love to help you. Anything we
Yeah.
can do to help.
All
And
right.
everybody out there, have a Merry Christmas. If that's a nice thing to say now, I don't know if
Happy
I'm saying it. Happy Hanukkah, happy
Year.
holidays, happy everything,
Yeah.
whatever it is.
Uh,
Enjoy yourselves, please.
yeah.
Be
Yeah.
nice to your fellow human being. Be happy.
That's it.
Say hello. Say good morning to somebody you don't know.
There you go. See, smile every day. That's it. A little bit of smiling.
You say good morning to somebody you don't know, you're going to make their day.
Yeah, they're actually going to be caught very off guard.
That's right.
They're going to be like,
Right.
that's it. Well, thank you so much. Good night, everybody.
You guys, good night.